I would like to warmly welcome you on this Thursday afternoon to our second symposium with the provocative title in question, will all radiotherapy be delivered in a maximum of 5 treatment fractions? The nickname of our symposium is 5 by 5 because we will present you 5 symposia distributed over 5 weeks. Let me start my screen sharing and give a quick introduction. Okay, so we are today in the second of our symposium here. Last week we addressed rectal cancer, neoadjuvant short course versus long course, and today we will focus and dedicate our time on breast cancer. What is the background here? Well, we all know that moderately hyperfractionated radiotherapy for breast cancer is the standard of care, and it is non-inferior, maybe even superior to conventionally fractionated radiotherapy after breast conserving therapy and after mastectomy. And as a consequence, it is the guideline recommended practice in whole breast radiotherapy, according to ASTRO, German, NCCN, and many, many more international guidelines. Last year, we have seen another game changer, the publication of the 5-year results of the Fast Forward trial and the 10-year results of the FAST trial by Andy Murray Brunt. The question is, well, the conclusion 26 gray in 5 fractions over 1 week. It is equivalent to 40 gray in 15 fractions in terms of tumor control, safe with a follow-up of 5 years. Of course, there's questions which we want to address. Is 10 years cosmesis follow-up, 5 years efficacy results sufficient? How do we select appropriately patients for 5 fraction radiation? And this is the evidence perspective, but also we have an implementation perspective, because we know that the implementation of hyperfractionated radiotherapy, it is challenging and can be challenging. This is data published this year by an ASTRO survey. 2,300 radiation oncologists participated, and the adoption of hyperfractionation for node-negative breast cancer following lobectomy was only 82%. And that dropped to much lower values for patients having experienced mastectomy or in node-positive patients. And this is data from Switzerland, a survey we have done in 2020. 22 of 30 radiation oncology department responded. That was in the middle or in the beginning of the pandemic. Before COVID, we had an adoption rate for hyperfractionation of 64%, which increased to 82% during the pandemic. Is that a durable effect? Something we will hopefully see. So before we go into the details, I would like to ask you some questions, whether you have already adopted 5 fraction radiotherapy in your clinical practice. So we will show 3 cases here, and please answer them here, and we will also show the results afterwards. The first question is, have you treated breast cancer patients with 5 fraction whole breast radiation in your clinical practice? A simple yes and no answer. So please respond here. The second question, what fractionation would you propose to a 60-year-old PT1B, P sentinel node negative, lymph node invasion negative, V0, grade 1, hormone receptor positive, HER2 node negative, no special type after R0 resection, breast conserving, 50 gray in 25, 40 gray in 15 over 3 weeks, or 26 gray in 5 fractions within 1 week. Then we do have a second case, which you can read here. It's a younger patient having a slightly larger tumor, a grade 3, and having a triple negative tumor, also after breast conserving surgery and after R0 resection. So please give us your responses here, and then we will quickly discuss the answers. Okay, so now we can see the results. We do have quite a substantial implementation already of 5 fraction radiation with 31%, but still the majority has not implemented 5 fraction radiation in his or her clinical practice. If we look at the 2 cases, we had one early case, elderly patient, small tumor, hormonal receptor positive. The majority would vote for 40 gray in 15 fractions over 3 weeks, plus minus boost. And if we move to the younger patient, a very similar picture where the adoption of 5 fraction dropped from 26% in the older case to about 7% in the younger case. So that gives us where we stand and can be used as a baseline. And obviously we're going to ask the same questions after the meeting to see whether we see any change in practice by our 2 presenters. Just some housekeeping remarks before we get started. We want to make that an interactive experience. So please use the question and answering functionality in Zoom to ask your questions. We will obviously not be able to answer all questions within this symposium, but we will answer them in a written format, and we will publish that on our symposium webpage. Also, the presentations, they will be recorded, and you can find them on our webpage, and this is the link here, you can easily find. CMA credits, they will be distributed via email, and please also evaluate the symposium, which will be possible after the end. With that, I would like to come to an honor to introduce our faculty. You can see here the 2 speakers, Professor Adrian Murray Brunt and Professor Paula Tsoutsou from Geneva, Switzerland. So let me stop my screen sharing and let me introduce Professor Murray Brunt. Professor Murray Brunt has been practicing for many years as a clinical oncologist at the University Hospitals of North Midlands. He was awarded as an honorary chair in clinical oncology at the Keele University in 2014 and the Institute of Cancer Research in London in 2017. In 2020, Murray moved from a clinical practice to a substantive chair at the School of Medicine, University of Keele. And most importantly for this symposium, Murray is chief investigator of the Fast Forward trial. So we will have hands-on first experience. Murray, many thanks for joining our symposium. We are eagerly looking forward to your presentation and the discussion afterwards. Thank you for joining, and the floor is yours.
Matthias, thank you very much for that kind introduction. Let me just set the screen up. So it's a pleasure to be talking to you all today on the topic of 25 to 5 fractions in adjuvant radiotherapy for breast cancer. Most of it is going to be about moving from 15 to 5. So I've seen from the questions that you've just answered that there is still use of 25 fractions of radiotherapy. And so the first few slides will very much still be relevant. In the UK, we've had a series of trials going from the late 1980s, from the START pilot study, and on the hyperfractionation, that moved to START, FAST, FAST forward. We've also done breast asymmetry trials, such as import low, which is already reported. So the question is, are we moving towards 5 fractions in a week? From where we were at 50 gray and 25 fraction in the late 80s, and stratified by risk. And I'll put this slide back towards the end of the presentation. So just to briefly mention the UK START studies, these were the long-term results. You'll see I've put a reference down there to Joe Haviland's paper. My final slide is going to have the publications, the web links of all the UK trials I'm going to put up today. And I'm very happy for you to take a screenshot when we get there. They're all open access, and so there's no need to scribble anything down at this stage. So START built on the START pilot study, which was masterminded by John Yarnold. Trial A was very similar, a 3-arm trial, 50 gray and 25 fractions over 5 weeks, and 2 arms of 13 fractions, giving 3 fractions in the first week, 2, 3, 2, 3, to get to 13. So most importantly, the time was the same, 5 weeks. So it's a hyperfractionated trial, but the overall time was the same. And so we were able to do some good radiobiological work on this, work on alpha betas without time being a confounding factor. At the same time, there was the pragmatic trial, trial B, which was really trying to look at a regimen that you might bring into the clinic. And that was comparing the 50 and 25 against 40 Gray and 15 fractions over 3 weeks. Primary endpoint, locoregional relapse, important secondary endpoints, including normal tissue effects. And the recruitment came from 35 UK radiotherapy centres, 1999 to 2002. Importantly, with the QA aspect, this was the first UK breast trial which included QA. There was a national centre set up at Mount Vernon, which is still functioning, and we put all our trials through there. And they're a great resource, so they're seen as a very positive centre from that point of view. The locoregional tumour relapse, it was a non-inferiority trial, so you can see on the left that we can say with great confidence that 40 Gray is non-inferior. At 10 years, the 50 Gray arm had a 5.5% recurrence rate, 4.3 in the 40 Gray arm, not statistically significantly different, but certainly non-inferior. And the cumulative hazard ratio on the right shows there were more events in the 50 Gray arm. And just get you to look at the hazard ratio, the odds ratio, 0.77. I'll come back to that in a minute. Any moderate or marked effect for a patient in any aspect that's assessed, it's a 4-point scale, moderate and marked being the top 2, and there is a significant difference here with the 40 Gray arm being gentler on the normal tissues than the 50 Gray. Hazard ratio, again, this is not why I said to notice it, but again, it's 0.77, but this one is a significant difference, and at 10 years, there's an 8% difference, absolute difference. And here to look at the forest plot, you can see everything is to the left of the line, some significantly, some not significantly here, but generally favouring hyperfractionation. I've perhaps unfairly called this a confirmatory study only because it does confirm the start results. It's an excellent trial run by Birgit Offersen from Denmark, but with Norwegian and German centres involved as well. And this shows the cumulative risk of locoregional recurrence in the invasive carcinoma cohort. There were some DCIS in this trial. No significant difference, but if you look at the hazard ratio, remarkably similar to start at 0.75. Again, not significant, but towards the hyperfractionated arm. So hence it's my term confirmatory study. And this was the primary endpoint of this excellent trial, cumulative incidence of grade 2 or 3 induration. Again, not significant. Look at the hazard ratio, very similar again, 0.75. So very similar to start. So many years later, this has supported the start results. At the end of start, we then wanted to look at what I would call 5-fraction hyperfractionation. I know extreme and ultra fractionation are terms that have been used, but I would call it 5-fraction hyperfractionation. And so the first study was really to see if it was feasible. We published the 10-year results last year in JCO. And this was deliberately a study of very low-risk patients because this was to look at normal tissue effects. So you can see here that they were T1 or 2, had to be node negative, age over 50, had to have conservation surgery. Randomized into 3 arms. We debated a lot, even all those years ago, should we have 40 in 15 or 50 in 25 as our standard? We went for 50 in 25. mainly so that it would have international standing, because the UK was ready to use 14 and 15 at that stage. 2 trial arms, keeping the time the same over 5 weeks. So 1 fraction a week for 5 weeks could be either 30 gray or 28.5 gray. So again, we've got the 3-arm trial. So we can do radiobiological work. We're not saying that one of these 2 would be the right dose, but you can extrapolate if you've got 2 schedules there that are test arms. Annual clinical assessment for 10 years, photographs at 2 and 5 years. The primary endpoint, in the same way as the Danish trial we've just seen, an early endpoint, is 2-year change in photographic breast appearance. Yes, the changes will continue for many years after that, but what we don't tend to see is a switch between the relative change between the arm. So that's why we were happy to have that as a primary endpoint. Secondary endpoints do include the longer term normal tissue effects, and we've included local tumor control. So what do we mean in the photographic appearance? This has been separately validated. It's just a simple 3-point assessment of the photographs: normal, mild change, and marked change. So top left, you can see a patient after surgery, before radiotherapy. Below that, years later, that's an example of no change. Top right, you can see a patient after surgery, before radiotherapy, and then bottom right, you can see a marked change many years later. So that's what we're talking about here. And the 2 and the 5-year results are shown here. The first thing you can see is the dark gray. So in all arms at 2 and 5 years, the majority of patients, the great majority, have no change at all. Most of the rest have a mild change. It's only a small number of patients at 5 years. You can see it's 2%, 3.8, 2.4% in the various arms have marked change. Statistically, that was significantly different, the 30 gray arm to the 50 gray arm, no difference between the 28.5 and 50 gray arms. Just to look at the top row here, local relapse, deliberately there was no intention to do any statistical analysis. We've seen only 11 local recurrences amongst the patients split between the 3 arms. So there's a 10-year local relapse rate of 1.3%. But the FAST trial showed us that marked adverse effects are rare, that late adverse effects after 28.5 gray, 5 fractions once weekly is similar to the 50 and 25. Local tumor relapse is low. And so this once a week schedule could be considered when a daily visit for 3 or 5 weeks, depending on what is standard, is not acceptable. So for a very frail patient, we are not putting this forward as a regimen for general consumption. But there are some patients that it's suitable for. The patients and the carers who've had this universally are very, very keen. The moment you mention it, they don't want anything but. So it's a regimen I've been using for many, many years. And this then fed into the Fast Forward study, which, as you know, we published the primary endpoint results, the 5-year efficacy and late normal tissue effects last year. And the aim was to find a 5-fraction schedule delivered in a week that's non-inferior for local control and as safe as the international standard 15-fraction regimen after primary surgery for early breast cancer. So eligible patients, invasive carcinoma of the breast, T1 to T3, N0 or N1, no metastases. We aim to recruit 4,000 patients on a 1-to-1-to-1 basis. So 40 gray and 15 fractions and 2 test arms, 27 and 26 gray, 5 fractions over a week. The boost has received some criticism. The boost had a lot of discussion before we launched the trial. Should we use a hypofractionated boost? Should we use a normofractionated boost? The logic was to use a hypofractionated boost, and indeed it almost ended up like that. But we felt that if we had a normofractionated boost, that would not be a variable. And then we'd just be looking at the breast. For each patient, the clinician had to state prior to randomization whether they were going to receive a boost and what dose they were going to receive. Patients are assessed annually by the clinicians up to 10 years. The photographs, we've got 2 and 5 years, and the PROMs also up to 5 years at the moment. We were given 4 years to recruit. We recruited just over 4,000 patients in just over 2.5 years from 47 UK radiotherapy centres and 50 referring hospitals. And we've got median follow-up of 6 years. Sample size of 4,000 came with discussion with patient groups in particular, and the trial management group, saying that it was absolute increase of 1.6% above standard would be unacceptable, anything less was acceptable. And the assumption was we would see 2% local recurrence in the standard arm at 5 years. Just a quick mention of the acute toxicity study, which we published in 2016. And that one I haven't included in the slide at the end. And this shows that all 3 schedules were acceptable. The solid line is grade 1 erythema, occurs in all patients in the 15 fraction arm, the great majority, but not quite all, in the 5 fractions. And then the dotted, the dashed line at the bottom, which is grade 2. Acute toxicity, of course, being related to total dose more than fraction size. So the 5 fractions are acceptable as we would expect. The demographics, median age of about 60, about half the patients were grade 2, just over a quarter were grade 3, just under a quarter were grade 1. They were stratified for randomization into low or high risk. High risk is age under 50, grade 3, or both, and that was just under 40% of the patients. The great majority had breast conservation, just under 7% had mastectomy. Almost 20% were node positive, and they would by definition all be N1. And you can see from status that 10% were HER2 positive and about 8% were triple negative. The minority of patients had a tumor bed boost, and most that did had the lower dose. So what did we see? So firstly, if we look at this, if you remember, I mentioned that we anticipated a 2% local recurrence at 5 years in the standard arm. We saw 2.1% in the standard arm at 5 years. 27 gray arm, it was 1.7%, 26 gray arm, it was 1.4%. Of course, we have data beyond 5 years. So what we have seen is 2.3% local recurrence in the 40 gray arm, 2% in the 27 gray arm, 1.5% in the 26 gray arm. And this figure just shows it with the red being the standard arm, the blue being the 26 gray arm. So this shows quite definitively that the 5 fraction arms are non-inferior to the standard arm. Local regional recurrence, overall 3.2% in the standard arm, 2.6% in the 27 gray arm, 2.1% in the 26 gray arm. Disease-free survival, no significant difference. Overall survival, also no significant difference. Late adverse effects, which are very important. So the clinicians assessed all patients on a 4-point scale, which you can see on the right. They're quite a bit and very much equivalent to moderate and marked. And for assessment, we've done the moderate and marked grouped together because there's very few in the very much grouping against the not at all and a little, so nothing and mild. Patients, for those centres that were putting into the sub-study of patient assessment and photographs, they put all their patients in, or what they were asked to offer it to all their patients. Again, the patients assessed on a 4-point scale, and the photographs, as we've already seen, on a 3-point scale. The percentages you see there are the moderate and marked added together. So at 5 years, it's 10%, any moderate or marked effects on clinician assessment in the standard arm, 12% in the 26 gray, 15% in the 27 gray. It was significantly increased in the 27 gray arm compared to the 40 gray arm, but not between 26 and 40. What I've just shown you is top left here. This is what we also looked at: breast distortion, induration, shrinkage, telangiectasia, edema, discomfort. And you can see how low some of these percentages are, the moderate and marked put together, and the dark gray, the nothing at all, by far the most common. Seeing it on a forest plot, first I'm going to show you this as the standard one, the relative treatment effects, which is the ratio you see at the bottom. On the green, the 27 gray, you can see with the asterisks quite a number of factors are significantly different. They're more in the 27 gray arm than the 40 gray arm. There is nothing that's significantly increased in the 26 gray arm compared to 40. Also shown is as absolute treatment effects, because the numbers we're looking at for moderate and marked are very low. And you can see, as we saw, just 10% of any effect, and the most common breast shrinkage was 5%, but some of the others are really very low. And also worth saying that with the multiple testing, it was predetermined that the significance level was going to be 0.005 because of the multiple testing that was going on. This is the patient assessment. The only significant finding was a harder and firmer breast with 27 gray compared to 40 gray. Otherwise, there were no significant differences. Percentages here again are the marked and mild together against the no change. And the majority of patients have no change or mild change only, but we do see a statistically significant difference for the 27 gray arm over the 40 gray, not for the 26 over the 40. So we were able to generate alpha betas for late responding normal tissue in the trial with the 2 test arms. If we look at the clinician reported moderate and marked adverse effects, we get an alpha beta of 1.7 gray. Photographic change, 1.8 gray. Patient reported change, 2.3 gray. Breast size, so large breast size. We know that a larger breast size, we're more likely to see an adverse effect, whatever the dose fractionation. We all see that, don't we? Long term, a larger breast is more likely to have a problem. But is it a problem with the hypofractionation, and particularly the 5-fraction hypofractionation? So when we looked at the clinician effect, if we had, and the 1.7 gray alpha beta was unadjusted, but if we adjusted it for whole breast planning treatment volume as a proxy for breast size, we got the same result. With the photographs, when we adjusted for breast size, we also got a very similar result. So that was reassuring, and that was as expected, really. So just looking at a simple number of alpha betas across the top, the schedule, obviously 15, 25 is when you're looking at EQD2, that's what we compare it against. So before the trial, based on the START trial, we were expecting an alpha beta around 3, in which case we would have anticipated, as shown here, that the 27 gray arm would be equivalent to the 40 gray. We had to decide on what the second arm would be. Again, there was some debate, some saying, surely that's too gentle, you should go higher. But actually, there might be a time effect. So we felt we should go lower. If the alpha beta was around 2, then the 40 gray and the 26 gray would be very similar. If in fact, it is as low as the 1.7 that we saw with the clinician assessment, you can see they're still very similar, slightly higher, value for 26 gray, but still more gentle than the 50 gray in 25 fractions. Looking at specialist referrals, just the top row to show you here, lymphedema, which of course is an early effect on the breast tissue. And there were a number of referrals early on to the lymphedema clinic for breast lymphedema. And that's what this signifies. And here, it's early for the long-term side effects, particularly, say, ischemic heart disease. So if you look at the very bottom row, that is for patients who didn't have pre-existing heart disease and had left-sided radiotherapy. So far, 6 patients who received the standard 40 gray arm had developed ischemic heart disease, and 3 patients who had the 26 gray arm. Absolutely no statistics done on that at all. And of course, we know there is no such thing as a safe cardiac dose. The aim is to try and remove the cardiac dose completely. Further look at the subgroups. So if we go back to the START meta-analysis, which was the pilot study, START A and B together. So some people are worried about younger patients. Well, you can see in the top there, that age, no significant difference, but looking at the forest plot, there's nothing to suggest a concern. Tumor grade 3, nothing to suggest a concern with hyperfractionation. The Tim Whelan-led work in Canada, hyperfractionation, they, following a central pathological review, looked at grade 3, which you can see in red here. And again, there was nothing to suggest a concern hyperfractionation for grade 3. So what did we see? Well, if we look at number of events first, age under 50, local recurrence, in the 40 gray arm, we've seen 3. I'll just concentrate on the 26 gray arm as the one of clinical interest. We saw 4 events. Grade 3. We saw 20 local recurrences after standard. We saw 8 after the 26 gray arm. We can say very little about the mastectomy. Certainly you can do no analysis, but out of 264 patients, we have seen only 1 recurrence on the chest wall, and the 173 patients who've had the 2 5-fraction schedules, there hasn't been 1 local recurrence. Triple negative, that worries some people. Triple negative, 10 patients out of 111 on the standard arm have had a local recurrence, and 3 patients out of 128 on the 26 gray have had a local recurrence. Just last week, we have published a further article looking at the potential for implementation of the 26 gray regimen, and this will be shown in a minute in my final slide. And there are no significant differences, but this shows it on the forest plot, what you've just seen on the figures. So the age under 50, grade 3, triple negative, there's no signals of concern. So what can we conclude? Well, both 5-fraction schedules are non-inferior to 40 gray and 15 for local tumor control. For late effects, 26 gray is very similar to 40 gray. The 27 gray is actually consistent with 50 gray for late effects. There's most definitely benefits to patients. There are benefits to healthcare systems. We've been on an unusual global situation with the pandemic in the last year. This was coincidental, but of course the fewer number of visits to hospital, great benefit. And in October, we had a UK consensus meeting to look at adopting 26 gray and 5 fractions, which we have done. And I'll just show you a couple of slides on that before finishing. There is an ongoing lymphatic sub-study comparing the 40 gray and the 26 gray arms, which will produce its first normal tissue results probably within a year, I would have thought, from now. So later this year or next year, I suspect. And last week, there was an editorial that came out on the breast consensus meeting run by the Royal College of Radiologists in the UK. This is the front and back pages, but it's open access. This, I don't expect you to read this, but this is in there. I've highlighted in red because I was asked about nodal radiotherapy. Nodal radiotherapy, until we get information, we would consider 40 gray and 15 fractions is standard. You will see on the slide that you can consider in the UK 26 gray and 5 fractions for nodal radiotherapy for a patient with significant comorbidities. We've also got guidelines that during the pandemic, if your hospital is under great pressure, that you can also use it for nodal, including internal mammary lymph nodes, which are not part of the nodal sub-study. So where have we got to? Back to this slide. On the right-hand side, we can say that 5 fractions in a week for patients with whole breast, chest wall, or linking in with the import low study, which we always plan to do at an early stage, partial breast radiotherapy, 26 gray in 5 fractions is now considered standard in the UK. That is what I acknowledge, and I will leave that up for the moment, so you can just have a look at those. That gives you the web link. It's all open access, including the 3 items that came out last week. So thank you very much.
Murray, many thanks for this excellent presentation, for giving this overview about the fascinating results. There's a couple of questions, and maybe Paula, myself, and the 3 of us can address them and discuss them. One of the questions has been obviously whether there are any risk groups which are more prone to either decreased local efficacy or increased cosmesis and toxicity. You pointed out quite clearly that you do not see any risk group according to the clinical parameters you've shown triple negative, you've shown age, but how do you do that in your practice? Do you use any patients where you would not recommend a 5 fraction, not mentioning the nodal issue?
So yes, without the nodal issue, there are no patients at all. So we will consider it for everyone. There have been comments, including the editorial that accompanied us in the Lancet, saying this is fine to be considered now for low risk patients, but not for high risk. But if you look at the various studies, START, the Ontario study, the subgroups in ours, nothing's significant, but the trend always with the higher risk patients, the triple negative, is towards the hyperfractionation. There are no signals of concern. Yes, we all have more concern about a triple negative patient than a low risk one, but that's because the breast cancer is higher risk. There are no concerns with regard to the hyperfractionation. So no, I will be happy for all patients. And in fact, those are the ones I'd almost want to consider more for 5 fractions. From the cosmesis point of view, we have a very small number only in the main trial of Fast Forward who've had a breast reconstruction. So I've shown with the mastectomy why we would have no concern. With the breast reconstruction, we've seen the 40 gray is much more gentle than 50 and 25. So certainly on the tissues, you'd be quite happy with that. The consensus meeting in the UK, deliberately, you will see when you look at it in detail, some said offer, some say consider. And so they consider if you've had breast reconstruction, you're allowed to consider 26 gray and 5 fractions. I would personally be happy. Others would like to see more evidence, but no, there are no patients that I would exclude.
You've shown that the numbers of moderate cosmesis changes, they are very low in absolute numbers. But for example, for breast induration, there was a higher absolute numbers for the 5 fraction regimen. You also mentioned that the relative difference, it will not kind of flip, but is there a risk, and how large would you estimate the risk that for the fast forward in a 5, 10 or 15-year outcome, that difference might become larger and might become more clinically relevant. How would you consider that concern, also based on the experiences of the START trials, where you do have long-term follow-up?
Yes, no, that's a very good question, and there's no doubt we've got to have the long-term follow-up, and we saw that with START. The UK adopted START after 5 years, but the 10-year confirmatory evidence was extremely important. With the induration, it was the induration outside the tumour bed. It was well under 1% in the standard arm, and it was about 2% outside the tumour bed in the 26 gray arm. That didn't hit statistical significance, but it certainly needs to be looked at. If we compare with say START, it's lower than we would see in the 50 gray arm. We expect, as time passes, we all know that induration, shrinkage, they will continue. We will see higher numbers at 5 years, 10 years, 15 years. What we have shown, and in the START trial, in the Ontario trial, in the FAST trial, is that the relative effects between the schedules are very similar at 5 years and 10 years. So we wouldn't expect a change in that. We will see an increase in the numbers. And yes, that of course is very important, but we're going from a low base. So I wouldn't at all dismiss it, and we must report that in due course.
There was also a couple of questions addressing the boost issue, and you have mentioned it, the long discussions in your group, whether you would go for a conventional fractionation. One question which was asked is, how did you choose between 10 gray and 16 gray boost? And the second question was, would you consider, and how would you estimate the simultaneous integrated boost technique in a 5 fractionation regimen?
Yeah, no, they're excellent questions. To my mind, generally, clinicians all over the place, we boost too many patients anyway, I think. If you need a boost, on my personal practice, I only ever use the 16 gray in 8 fractions. If you're going to give a boost, I think you need to give a decent dose. But I was in the minority there. The majority chose 10 gray in 5. So they chose it for their own reasons. There's such a variability of practice from hospital to hospital, team meeting to team meeting. The factors that are given, I mean, I have specific factors in my own head as to why I would give a boost, but there are lots of other factors that come into it. Some I wouldn't agree with, some others do. So I think our indications are very variable all around the world on that. In the nodal sub-study, we have allowed hyperfractionation, and the two most, but all we've said is to be equivalent somewhere between the 10 in 5, 16 in 8. My personal favored one was to go with the same fractionation as 14, 15. So I was given 13.35 in 5, 12 in 4 was another common one, but others had a variation. There's no direct information on the simultaneous integrated boost and the 5 fractionation. There's radiobiological work that can make some estimation, and there has been quite a bit of that going on. I think the SIB is going to be the way forward. In the UK, we're particularly waiting for the import high study. So anyone going to ESTRO this year should keep their eyes peeled from that point of view. And so we, in the consensus statement, we have said that if you're going to use 26 in 5, at the moment, you should use a sequential boost because there isn't information on what level to use. I mean, I think you could argue from radiobiologically about 30 gray perhaps, but there isn't the information. On the 15 fractions, we would say the boost is 48 gray and 15 fractions for the SIB. But yes, I think a lot more is going to come out about that. I'm sure that's the way forward as well.
Another question which was frequently asked is about technique for irradiation. How hard do you push the homogeneity of dose distributions, in particular also in patients having a large breast? So have you kind of adopted, changed your quality assurance, your treatment planning processes, the requirements in terms of dose heterogeneity in the 5-fraction regimen compared to 15 or 25 fractions?
So we were very much going on similar to our standard, really, outside the trial from that point of view. And there's been quite a bit of work, and some people like John Yarnell, Soren Benson have reported quite a bit on the so-called triple trouble, and looking at the larger breast. And there's really very little information to support that. There was a sub-analysis done of the FAST study by Yat Sang, I think 2013, to look at that. And there really wasn't a particular problem. So from the point of view of your technique, if you're going to take on the dose fractionation, I don't think that your technique needs to change. And techniques, of course, become very personal to centers, don't they? And you get really good at delivering your own technique with your own vagaries. So I wouldn't be suggesting wholesale changes from that point of view. So if you've got a technique that works, stick with it and develop it as we're all developing and changing. So I don't think that we need to do anything specific from that point of view.
Okay, also looking on the time, we have now 5:50. Thanks again for this excellent presentation and for answering all the questions which have been asked here. I hope you're going to stay for the rest of the symposium. We have one more exciting speaker, which I'm very proud to introduce. Paula Tsoutsou, she's head of the Radiation Oncology Department in the Geneva University Hospital, as well as associate professor in the Faculty of Medicine at the University of Geneva. Her main research interest is obviously in the field of innovative radiotherapy for breast cancer, the integration of breast cancer heterogeneity into radiation oncology, and prevention of radiotherapy toxicity by innovative radiation modalities. And we gave you a tough topic, but a topic where we know you're actively working on in the framework of translational and also clinical trials. How about neoadjuvant radiation for breast cancer? Paula, many, many thanks for joining, and we're looking forward to your talk.
Thank you, Matthias. Thank you for this invitation. It is a great pleasure for me to be among you today. So my task is to discuss neoadjuvant radiotherapy in breast cancer as an innovative approach. And this is what I'll do within the next 10 minutes. So you all know that radiotherapy... Okay. You all know that radiotherapy has historically permitted breast preservation. It has been associated initially with local control benefits and overall survival benefits, and traditionally radiotherapy has been delivered in the post-operative setting. So why think of inversing the sequence of radiotherapy and deliver radiotherapy preoperatively? There might exist indeed some potential clinical benefits that might be related to downstaging, thus increasing operability or breast conservation chances. There might be some modern benefits associated to improve outcomes after reconstruction, because radiotherapy before surgery, before reconstruction, might be more simple to deliver and also might be more beneficial in terms of toxicity through avoidance of irradiation of expanders, implants, or flaps. And it might also be associated with a chance to increase pathologic complete response, which, as we know, is a surrogate for overall survival, at least for some breast cancer subtypes. And this concept might also represent potential technical benefits, because as radiation oncologists, we know that it is always more easy to target a tumor that is in place and that we can see. And we all know the limitations of standardization of target volumes when we have to deliver a post-operative boost or to define our volumes for partial breast irradiation. So I will briefly describe the different contexts within which preoperative radiotherapy has been tested in the context of breast cancer irradiation. Preoperative radiotherapy as whole breast, solely whole breast radiotherapy is in fact an old concept. It is a concept that has been tested in the 70s, 80s, at the time where we were trying to understand what is the sequence and what is the place of every adjuvant treatment. And here I present the curves from a large Swedish study that included almost 1,000 patients and which compared preoperative to postoperative radiotherapy to no radiotherapy at all. And as you can see, no radiotherapy at all was worse in terms of disease-free survival and overall survival, while there was no difference between preoperative and postoperative radiotherapy. And globally, there are a few series with limited numbers of patients. This is not good quality data. I will not present you the quality of data that you just saw when I discussed preoperative radiotherapy. This is clear. But in all these series, we see globally no difference in outcomes, and we attain pathologic complete response rates that are about 10%, and which can be up to 26 to 30% for triple negative breast cancer for whole breast radiotherapy only in the preoperative setting. Another context within which preoperative radiotherapy has been naturally, I would say, tested is the context of locally advanced breast cancer. Locally advanced breast cancer is the setting from which neoadjuvant chemotherapy has emerged as the preferable treatment option. Initially, it emerged because it provided opportunities for breast preservation and opportunities for operability. So it was a quite natural idea to add also radiotherapy in this setting and to associate it with chemotherapy. And indeed, what was seen was that the addition of radiotherapy slightly increased the PCR rates from 20 to 30, 35% in unselected populations. And in this retrospective large series that comes from Düsseldorf, we can see that PCR, pathologic complete response after local regional treatment of radiotherapy and chemotherapy, was also retained its prognostic significance for survival, and also that there were more chances of obtaining PCR the longer we waited between radiotherapy and surgery. So here again, we do not have good quality data, but it seems to work. It seems to increase slightly the pathologic complete response rate, and it seems to be related to time intervals between radiotherapy and surgery. The third setting where whole breast radiotherapy has been tested is the setting of immediate breast reconstruction. This is an unmet clinical need today because we do more and more immediate breast reconstruction. We know that it is technically challenging. We know that it is associated with increased risks of toxicity and reconstruction failure. So the idea was, why not irradiate before we have implants, or we have expanders, or we have flaps? And this has been tested in small series that were not randomized. And here I present data from a series from Montpellier, where they irradiated patients before nipple-sparing mastectomy. There were 80 patients, and 5 of them developed skin necrosis, which was the main endpoint of the study. So these were considered encouraging results, and indeed, these are lower than the ones that are reported in the literature. However, if you look at the whole of the series that have been published so far, the outcomes between preoperative and postoperative radiotherapy in this setting do not seem to differ. And now I will move to another concept of preoperative radiotherapy. Until now, I have described whole breast irradiation before surgery. I would like now to describe partial breast irradiation before surgery. As you know, partial breast irradiation has become a standard option in selected populations of low-risk patients. So why deliver partial breast irradiation in a lumpectomy cavity, and why not deliver it when we have the tumor in place, which would result to a better defined volume and to a decreased volume and possibly to decrease the toxicities. And here you can see two series where they have tested 10 fractions of preoperative partial breast irradiation, and they showed relatively good tolerance data, but with a follow-up that is still short. To move forward within this concept, which I find quite fascinating, I'll present you some studies that have been undertaken with preoperative stereotactic radiotherapy in the breast. The first studies were the studies by Bondiot. Bondiot delivered the SBRT associated to neoadjuvant chemotherapy in locally advanced breast cancer. It was a dose-escalated study that was followed by standard radiotherapy, and he obtained quite interesting PCR rates, and the whole regimen was well tolerated. So this was a study that was quite provocative and interesting, and was followed by next by the group of Duke University, Jenny Horton, who delivered 1 fraction of preoperative SBRT at 21 gray to low-risk patients and within a phase 1 dose escalation study. And this study did not, no patient presented any dose-limiting toxicity. Fibrosis remained very mild. And this study is interesting. I'll show you why in the next slide, as well as this one coming from the Dutch group led by Vasmel, who also delivered 1 fraction of 20 gray, but also had an elective volume of 15 gray around the tumor that was identified under MRI guidance. This Vasmel study reported very interesting PCR rates that reached up to 48% at 8 months with 1 fraction radiotherapy delivered in the preoperative setting. This is very interesting result delivered within 1 fraction, and in terms of toxicity, it was very encouraging with no dose-limiting toxicity. Why do I find these studies so interesting? Because these studies, here you see the Horton results on toxicity. You see that they had excellent to good cosmetic outcomes evaluated by patients and by physicians. But what I find even more interesting is that in this study where they delivered 1 fraction of preoperative radiotherapy and they operated 10 days after the delivery of radiotherapy, they already could see in the MRI vascular changes, changes in imaging, and more than that, they could also see when they compare the biopsy specimens and the surgical specimens, they could see that several set of genes related to inflammation and related to immunologic response were increased in a dose-dependent manner after 1 fraction of preoperative radiotherapy. And this, I think, it is fascinating because it permits us to better understand the interactions of radiotherapy and breast cancer. And if you look at the Vasmel study, which I show here, they evaluated the capacity, the predictive value of MRI in terms of response. And indeed, it was not so encouraging because it was around 70% negative and positive predictive value. And they also were able to show that the longer we waited, the more chances we had to have a radiologic complete response and a pathological complete response in data that I don't show here. So what have we learned from these studies? We've learned that preoperative SBRT might be an opportunity to explore the role of radiotherapy in breast cancer. And here I present you a study that we started in Lausanne, where we deliver preoperative SBRT as immunostimulatory factor associated to immunotherapy with an exploratory translational part where we will try to understand what are the effects of radiotherapy in breast tissue of triple negative early breast cancer patients, or we can use it if we dose escalate, given the background of the phase 1 studies that I have presented, as an opportunity to provide a non-invasive treatment to patients who cannot receive surgery. So I believe that preoperative radiotherapy is indeed, although there are open questions related to patient selection, fractionation and dose, delay from radiotherapy to surgery and combination, is indeed an opportunity because apart from the clinical benefits, which might be to increase the PCR rate, to preserve more breast tissue, it is a great opportunity to better understand the effects of radiotherapy in breast cancer and to better understand the radiotherapy combinations. And from this point of view, I think that we should focus, when we discuss about preoperative radiotherapy, on exploratory questions. Thank you.
Thank you, Paula, for the excellent overview about a very innovative topic, which when also kind of might give us a different perspective on breast cancer. Before we go into the final discussion, I would ask Michael to show us the initial questions and see whether we have a change in practice according to the two presentations we've seen. Michael, please start the questions again. Okay, so you can see the questions which we have asked before. It's the same cases, so you do not need to read in details. It's an elderly patient, with low risk early breast cancer, and it's a younger patient having triple negative breast cancer. Would you consider, after what you heard now, a 5-fraction radiation schedule in these patients? Please vote. We can see quite a change, something which is not frequently seen in such kind of symposia. So I'm very happy. Maybe Murray, you want to comment them, because that addresses obviously your talk, and you seem to have made quite a difference and had an influence. Please, Murray.
Well, firstly, obviously, I'd like to praise the audience and for their attention. Which was very good. I'm still interested to see that the 5 fractions is more easily taken up for the lower risk patient than the higher risk patient. And I think it's still this perception. We are worried about the higher risk patient, but we're actually worried about them because of their breast cancer, to my mind. And I think if you're happy to give 5 fractions for the lower risk one, why not the higher risk? But I would say that's yes, that's a significant shift. So very pleased to see that, Paula.
Can I ask you a question? Because I also share this concern about high risk patients. One reason for this is because from a radiobiological point of view, I do not see why luminal lay breast cancer would respond the same way as the triple negative or HER2 positive breast cancer. And the other reason is because we don't have, these patients are underrepresented in the first studies. There were, I think, 8% of triple negative and 8%, 10% of HER2 positive patients. So we do not have selective data on these patients. Given I agree with you that with a follow-up of 5 years for these high-risk patients, we should have events that should be indicative, but still.
I mean, if we take the triple negative as sort of perhaps the most worrying group of the lot, yes, there were only about 8% of patients, but if we look at there were 111 patients in the 40 gray arm, 10 recurrences, 128 patients in the 26 gray arm, 3 recurrences. So statistically, of course, that's not significant because such small numbers, but there are no signals of concern. And if proliferation is something that's important, we haven't got time really to explore the full radiobiological, but the START trial did put out a hypothesis in a paper 2015 or 16, I think it was, looking at the lost opportunity and the reason why, even though the EQD2 is lower with 40 in 15 than 50 and 25, you're seeing certainly it's non-inferior, and it was saying if the difference is real. And of course the Danish-led study has shown that. We may then see that if you go down to a week and you follow that radiobiology through, that there is a way of working out that the 26 gray is actually a much higher EQD2 if we look at biological effective dose rather that it might be higher than certainly 50 and 25 and also 40 and 15. Hypothesis purely. I mean, I'm not putting that out as fact. I must say that. But the proliferate, and I was interested to see your sort of proliferation. We do something, because generally we don't think of breast tumors like, say, head and neck tumors, high proliferation. But usually by the time we give them radiotherapy, they've had surgery and or chemotherapy. And so the proliferation may be very different by the time we give them radiotherapy. So the time factor is fascinating. Hypothesis debate, nothing, I'm not putting up for anything more than that at the moment.
Maybe one final question, which I would like to ask you, Paula. When you presented your neoadjuvant work, I mean, the best data, as far as I know, for partial breast irradiation is for interstitial brachytherapy. Would you think that might be also worthwhile exploring in the neoadjuvant concept to achieve even better normal tissue sparing, and in particular skin sparing, compared to using an EBRT SBRT approach?
Well, brachytherapy was the best option until the publication of the Florence data, which I personally very much liked, because it is a very practical and easy to deliver schedule of 5 fractions, which has very good also toxicity and oncological outcomes. I don't know if you share my enthusiasm for this data, Professor Brunt, but I would, yes, why not consider brachytherapy? Brachytherapy is always limited by expertise, availability, and the invasive nature, but it would certainly be interesting to deliver it preoperatively. What we have seen, there is a small study that has been published in EORT data, and we see that there are even immunologic effects after EORT, after intraoperative radiotherapy. So I think that it is very exciting to explore what happens when we irradiate the tumor that is in place. This will give us a lot of information on local radiobiological features, but also on systemic effects of radiotherapy. And brachytherapy is certainly, given its unique nature, an option that merits to be explored, in my mind.
Okay, with that, we have now 6:10, so we're a few minutes past, but I think the 2 presentations in particular, but also the discussion was fully worth it. Thank you very much, Murray and Paula, for joining our symposium. Thanks for great presentations and for an excellent discussion. Thanks everyone for joining. Thanks for your interest. As mentioned, you will receive your CME credits via email. You can see the presentation on our symposium homepage, and you will be immediately directed to a SurveyMonkey for evaluation of our symposium if you leave the Zoom meeting. Everyone stay safe, enjoy a hopefully sunny day, and hopefully see everyone next week and also at ESTRO in a physical meeting. Bye everyone, have a good evening.
Bye, and thank you for the great event.